Hey guys, back with cardiac alterations. Now, what you can see up on the wall is everything from cardiac other than EKG and then your cardiac output. So I'm going to do a separate video on cardiac output because I myself am still struggling to understand preload, afterload, contractility, all that kind of stuff. So you'll see another video on that, don't freak out, and you'll see another video with EKG. So all this, I took what I found was the most important. So I have eliminated some of the diagnostic tests, treatments, stuff like that. Again, you study what you need to study. This is what helped me the most. So starting out with chronic venous insufficiency. Now, this can be caused by deep vein thrombosis. And then the manifestations for chronic venous insufficiency, you're going to see blood pooling and edema. That goes into deep vein thrombosis. So the etiology for deep vein thrombosis is the triad of Virchow, which we just got done talking about at the end of hemolytic. That was your thromboembolic disorders. DVT is one of them, your deep vein thrombosis. So your triad of Virchow, to review, it's comprised of venous stasis. If you have venous endothelial damage, so trauma, and then hypercoagulability. And then in order to diagnose deep vein thrombosis, you're going to need a Doppler ultrasound, and then in order to treat it, you're going to use anticoagulants and an IVC filter. You do have some possible complications with DVT, and that's going to be pulmonary embolus, CVA, which is also cerebral vascular accident or stroke, and also myocardial infarction, which seems to be part of all of them. All right, moving on to hypertension. So the areas damaged with hypertension are going to be your brain, your eyes, your heart, and your kidneys. And then hypertension is also known as the silent disease. So it's very asymptomatic. Sometimes the only things that you'll see is just an elevated reading. So it's a good thing to pay attention to. Treatment includes limiting, I chose 3 of them, limiting sodium, stress, and smoking. So there's a lot more of them, but it's basically getting healthier, making healthier lifestyle choices, eating better, exercising more, not doing things that are bad for your body are basically the treatments for hypertension. It is more common in older people, specifically men. Men have a higher incidence of hypertension than women, and it's also more common in people of an African ancestry. All right, so we do have 3 types of hypertension. We have primary, secondary, malignant hypertension. Primary hypertension is also known as essential hypertension. This involves an increased arterial vasoconstriction, and the readings are going to be higher than 140 over 90. There are some stages in there. Go and review that for yourselves. I'm only memorizing this portion. Secondary hypertension. This is going to result from either renal disease or pheochromocytoma. Again, go look that one up because I have no idea what it is. And then for secondary hypertension, keep in mind that the underlying problem needs to be treated in order to treat the hypertension. Lastly, we have malignant hypertension. This is also known as resistant hypertension. Malignant hypertension is rapid and uncontrollable. No, screen, don't go dark. It is characterized by high diastolic pressure, and a thing to keep in mind is that a diastolic pressure greater than 140 is life-threatening. Granted, I think it would even be lesser than that, but 140 is life-threatening, okay. And then signs and symptoms of malignant hypertension include cerebral edema and ICP, which I believe is increased cranial pressure, which makes sense with a cerebral edema. Okay, done with hypertension, moving on to aortic aneurysm. So an aortic aneurysm is defined as a localized dilation or weakening of an arterial wall. It may be caused by, now the way I memorized this was CAST, C-A-S-T. So basically an AA cast, so Alcoholics Anonymous cast. That's how I put it together. But for CAST, it stands for congenital defects, atherosclerosis, syphilis, and trauma, C-A-S-T. All right, the signs and symptoms of an aortic aneurysm, you're going to either be able to hear bruits upon auscultation, or you're going to be able to feel the abdominal pulse when you palpate. Now, the big thing to know about aortic aneurysms is, similar to hypertension, they are usually asymptomatic until they rupture. And when they rupture, you can have moderate bleeding, but most likely you're going to have severe hemorrhage and you're going to die. So keep that in mind. It's fairly severe. All right, and lastly, you do have three types of aortic aneurysm. You have fusiform, saccular, and dissecting. Your fusiform, I guess the best way to describe it, you have an entire bulge. So you have the vessel or whatever, and then it goes into a bulge like this, and then it keeps going down. So you're gonna have your blood flow going down, and then it's gonna go on either side of that bulge, and then keep going. Go ahead and look at your pictures and your notes here. You know what? Hold on. Make this easier. So this is what you're going to see. I know it might be backwards in the video, but okay, so this was what I was describing for fusiform, and then you have saccular. So you kind of have a sac, and then you have a thrombus. So the blood flow kind of goes in and out, not good. And then last one you have is dissecting, and that's when you actually have a tear in the intima, and the blood kind of flows in there, as you can kind of see. Okay, so let me put this back down. All right, so that's aortic aneurysm. Moving on to arteriosclerosis. So arteriosclerosis is characterized by an abnormal thickening or hardening of the vessel walls. And good thing to know is that arteriosclerosis is a chronic disease, not acute. The most common form of arteriosclerosis is atherosclerosis. And this is the leading cause of coronary artery disease, which we'll talk about down here, and I think it's either cerebrovascular or cardiovascular disease. Okay, so moving on to PVD, which is peripheral vascular disease, which is a type of atherosclerosis. So the peripheral vascular disease is a disease in arteries outside of the heart. So you're going to see it in your arms, your abdomen, your legs. Specifically, the most common sites are the abdominal aorta, the carotid arteries, the femoral, and the iliac arteries. And there is an increased incidence for peripheral vascular disease in those with diabetes. All right, in order to diagnose peripheral vascular disease, the blood flow has to be assessed by a Doppler study, and you can also use arteriography. You do have a lot of signs and symptoms, and most of them have to do with your legs. So I would say if they mention anything on the test about legs, we're talking about either deep vein thrombosis or peripheral vascular disease. But for peripheral vascular disease, you're going to have fatigue, weakness, and claudication. Now, claudication is, you're going to have intermittent claudication with PVD, and that's going to be like intermittent leg pain. So sometimes it's going to be there, sometimes it's going to go away, depending. I think it's described as when we're walking, like occasionally you'll feel the pain. You're going to have some sensory impairment. You're going to feel some tingling, burning, and numbness in the affected area. And then for feet and leg appearance, they could be pale, they could be cyanotic. The skin on the feet and the legs is going to be dry, hairless, and your toenails are going to be thick and hard. And then a good thing to note is that peripheral pulses distal to whatever occlusion is going on, those pulses are going to become weak. So if you've been in clinicals already and anybody's had deep vein thrombosis or any other issue going on in their leg, oftentimes you can't feel those pedal pulses when we do our 5-minute assessment. Okay, so moving on, this is just going to be a quick review of the diagnostic tests for cardio function. Because again, I'm not trying to memorize all the diagnostic tests and everything else. But I did come up with an acronym for diagnostic tests, and it's excuses. So the way that I remember it is we always make excuses for how we feel. So for the first E, it's echocardiography. The X is X-ray. The C is cardiac catheterization. The U is, I'm taking the U out of Doppler studies because you have to use Doppler studies in order to diagnose. Stress tests, so the EKGs, electrocardiography, and then the last S is S, like S-E-E. And it's for angiography, because an angiography is actually when they go in and they're like looking inside the lumen, so they're seeing what's going on. So that's the only way I was able to make a full mnemonic for it. Okay, so those are the diagnostic tests for cardiovascular function, and then we have blood tests in order to diagnose what's going on. And that mnemonic I came up with was CELLS, CELLS. The first one is cholesterol, electrolytes, LDL, and I took the H out of HDL, so HDL is the next one, and then the last one is serum triglycerides. Again, I'm not memorizing all of that, but at least I would probably recognize it if she decides to throw a curveball in there. Okay, coronary artery disease. So coronary artery disease is a continuum that impairs the pumping ability of the heart. Now, this disease is going to deprive the heart muscle of oxygen and much-needed nutrients. And then you have this is where you see the modifiable, non-modifiable, traditional risk factors and all that kind of fun stuff. So the ones I thought were important, the non-modifiable risk factors include age, gender, and family history. Then you have your modifiable risk factors. Now this goes back to when you're trying to treat like hypertension stuff, it's get healthy. I mean, that's the biggest thing. The risk factors, so like in this you have hypertension, smoking, diabetes mellitus, obesity, dyslipidemia, all things that you can control with choices you make. So exercise, dieting, all that kind of stuff. And then the non-traditional risk factors include markers of inflammation and thrombosis. So this is where you're going to the C-reactive protein. Hyperhomocysteism. No idea what it is. Feel free to look it up and let me know. And infection and periodontal disease. So this is the only thing I saw about periodontal anything is for coronary artery disease. If she decides to throw it in there, I have no idea. Okay. All right, so we're going to take a break, and then we'll start in on myocardial ischemia.